Okay, let's dive in. We got a stack of revision notes here, all focused on one specific topic, Group B Streptococcus.
GBS. Yeah.
This is quite a significant topic, especially when we think about newborn health. And these notes, they look like they really pull together the essentials you'd need for revision.
Absolutely. Think of these notes as like your map. Covers the basics, what GBS actually is, right through to how it's managed. Particularly focuses on things like the UK guidelines, the RCOG ones.
Right.
So our mission here really is to unpack these notes for you, go through the key points, make sure the really critical high-yield information is clear and hopefully memorable.
Exactly. Cutting through the noise straight to what these notes say is most important. So, okay, let's start right at the beginning. What is GBS, according to these notes?
Okay, so at its core, GBS is a type of bacteria, Streptococcus agalactiae.
Streptococcus agalactiae, okay.
And a really crucial point from these notes, it's incredibly common. It often just lives harmlessly in the gut, the gastrointestinal tract, and also the genital tracts of perfectly healthy people.
So you can be a carrier and not even know it.
Precisely. You might have no idea.
Yeah.
It doesn't necessarily cause problems for the person carrying it.
The notes are very clear about who it can cause problems for.
Yes, exactly.
Mm.
While it can cause infections in, say, pregnant women or other adults, the notes really emphasize its major significance for newborns. It's flagged here as the single most common cause of early-onset severe infections in babies.
Wow. The most common cause.
Yeah, and that links back to the carriers, you see, because the notes state that a pretty significant chunk of mothers, maybe 20 to 40%, carry GBS.
20 to 40%, that's quite high.
It is, and that's the pool, essentially, where these newborn infections often originate from.
That statistic alone really shows why this is such a relevant topic for, pregnancy and childbirth. Which leads us nicely to, well, how does someone get it? The etiology. What did the notes say?
The cause is straightforward. It's the bacteria itself, Streptococcus agalactiae.
Right.
And the main way it gets passed on, especially to newborns, is during childbirth. As the baby travels through the birth canal of a mother who's a carrier, they can get exposed. Direct contact is also mentioned as a possibility.
So exposure during birth is the key route for babies, which makes identifying who's at risk really vital. The notes seem to lay out the risk factors quite clearly, focusing on newborns.
They do, and this section of the notes, definitely high yield for revision. They group them quite logically. First, you've got maternal factors.
Like the mother herself.
Exactly. If the mother is known to be a carrier, that's a primary risk for the baby. Also, intrapartum fever, so a fever developing during labor. That's another big flag.
Okay.
And importantly, if a mother has previously had a baby with a GBS infection, well, that significantly increases the risk for her next baby.
Right, so mother's carrier status, fever in labor, and past history. Got it. What about factors related to the labor itself, the delivery process?
Yep, those list three key ones there. Premature rupture of membranes, water's breaking early.
Before labor starts properly.
Or just too early. Yeah, it removes that protective barrier. Then, preterm labor itself, so delivering before 37 weeks. The baby is just more vulnerable.
Makes sense.
And finally, prolonged labor. Basically, the longer the labor goes on after the waters have broken, the more time there is for potential exposure.
Okay, so early exposure, longer exposure, or exposure when the baby's more vulnerable or less protected. Looking at these notes, these factors really paint a picture of high-risk situations. Definitely points to remember.
Absolutely. Those are the triggers, the things that should make you think GBS risk in a clinical setting based on these notes.
Okay, so that's the risk of getting it. What about what it actually does, the pathophysiology?
The notes mention two main patterns of infection in newborns. There's early onset.
That's the one happening soon after birth.
Yeah, typically within the first week of life.
Yeah.
Often acquired, like we said, during passage through the birth canal. And then there's late onset disease.
Which happens
Later. From about day 7 up to maybe 3 months old. And the source there could still be the mother, but maybe other environmental sources too.
And how does it cause illness?
Well, the notes explain the mechanism. The bacteria gets in, it can invade the bloodstream, that's bacteremia,
Right.
and from the blood it can spread. It can affect multiple organs, lungs causing pneumonia, or the brain membranes causing meningitis.
So it can become systemic, affecting the whole body.
Exactly. And the notes do remind us, while the big focus is often on newborns because it can be so severe for them, pregnant women and other adults can also get GBS infections, UTIs, postpartum infections, various things.
Okay, so it's not just a newborn problem, though that's where the highest severity risk seems to lie, according to these notes.
Correct. Severe invasive disease is less common in healthy adults, but it definitely happens, especially if someone has other health issues. The notes include this for a complete picture.
Now, when you see symptoms, maybe sepsis in a newborn or UTI in pregnancy, you need to consider other causes too, right? Differential diagnosis.
Yes. The notes are pretty brief here, but make the key point.
Mm-hmm.
You need to rule out other things, especially with something like neonatal sepsis. It could be other bacteria, maybe even viruses. Same for infections in pregnant women.
So think GBS, but also think, what else could this be?
Precisely. Got to find the right culprit to treat effectively.
Okay. So putting this in context, how common is GBS infection? The notes seem to lean towards UK data, especially with the management guidelines mentioned later. What do they say about epidemiology here?
They give a really stark statistic for the UK. GBS is the leading cause of severe infection in newborns.
The leading cause. That's significant.
It immediately tells you why this is such a high-priority topic in UK maternity and pediatric care. The notes also give an estimated incidence figure, about 1 in 750 live births.
1 in 1750.
Doesn't sound like a huge number, maybe, but you multiply that by the total number of births each year, and it adds up to a significant public health issue. A lot of affected babies.
Yeah, that puts it into perspective. So when these infections happen, what do they actually look like? The clinical presentation, the notes break it down by group.
Right. For newborns, the picture can be really serious, often developing quickly. The notes list the big ones. Sepsis, that life-threatening whole-body response to infection, pneumonia infection in the lungs, and meningitis inflammation around the brain and spinal cord.
Very serious conditions.
Absolutely. And the notes also mention other systemic signs, things like the baby being very lethargic, not feeding well, having trouble breathing, signs the infection is widespread.
And what about for pregnant women or other adults? What presentations do the notes list?
More commonly there, it mentions urinary tract infections, UTIs.
Yeah.
Also, postpartum infections cropping up after birth, like in the womb or a C-section wound, and other invasive infections are possible too.
So it really varies. Often severe systemic illness in newborns, but perhaps more localized, like a UTI, in adults, though serious infections can still happen.
Exactly. The presentation really depends on the patient group and their overall health, as highlighted in the notes.
Okay. Recognizing the signs is step one, but how do you actually confirm it's GBS? Or how do you find those carriers before problems start? What do the notes say about investigations?
They outline two main approaches. First is prenatal screening.
Screening during pregnancy.
Yes. Using swabs, usually vaginal and rectal swabs, typically later in pregnancy. The goal, as the notes suggest, is to identify women carrying GBS before labor starts.
So you know who might need preventative treatment.
Exactly. And the second approach is laboratory tests, used when you actually suspect an infection is happening.
So testing samples from the baby or the mother?
Right. Taking samples like blood, urine, or if meningitis is suspected, cerebrospinal fluid, the fluid around the brain and spine, looking for the Streptococcus agalactiae bacteria.
And crucially,
The notes mention antibiotic susceptibility testing. This is vital. It tells you which specific antibiotics will actually kill that particular strain of GBS the patient has.
so you can pick the right drug from the start.
Ensures effective treatment. Hugely important.
Which leads us perfectly into the management section. This looks like a really key part of the notes, and it specifically mentions UK practice, referencing the RCOG 2017 guidelines. What's the overall strategy outlined there?
Okay, so the core strategy in these guidelines, especially for preventing that early-onset GBS disease in newborns, is something called Intrapartum antibiotic prophylaxis, IAP.
Intrapartum. So during labor.
Yes, giving antibiotics to the mother during labor. But, and this is a really key point emphasized in the notes, this isn't for everyone. It's targeted. It's primarily for women identified as having specific risk factors.
Ah, so it links back to that risk factor list we discussed earlier. It's not universal screening and treatment for all.
Not universal screening, no. That's a defining feature of the UK approach described here. So IAP for those with risk factors.
And if a newborn does get infected or is suspected of having an infection,
Then the notes say they receive antibiotics directly. Treat the baby. And similarly, maternal or adult infections are treated with appropriate antibiotics based on the situation and guidelines.
okay. Now, the notes seem to pull out some very specific points from those RCOG 2017 guidelines. These feel like the absolute must-know details for UK practice. based on these revision notes?
Definitely. These are the high-yield takeaways from the guidelines section of the notes. First, they explicitly state no universal GBS screening for all pregnant women in the UK.
Okay, that's crystal clear from the notes. No routine screening for everyone.
Following from that, the notes mention that just because a woman asks for screening, that alone isn't considered enough reason to do it under these guidelines. It needs to be based on risk factors or history.
Right, reinforces that risk-based approach. What if a mother had a previous baby with GBS disease? That was a risk factor.
Yes, a major one. The notes state that a history of a previous baby with GBS disease is a clear indication for action. These women should be offered IAP automatically during labor in their current pregnancy.
Offered IAP.
Or, the notes say there's an alternative option for them. They can choose to have GBS testing done late in this pregnancy. Swabs again. And if that test comes back positive, then they get the antibiotics during labor.
So offer IAP, or offer testing, and treat if positive. And if testing is done, when should those swabs be taken? Do the notes specify?
They do. The timing mentioned is between 35 and 37 weeks of gestation, or if delivery is expected earlier, then about 3 to 5 weeks before the due date.
Okay, 35, 37 weeks. Good timing to predict status at delivery, presumably.
Seems likely, yeah. The notes then reiterate the main indications for offering IAP during labor, the triggers based on risk.
Which are?
Listed here as having had that previous baby with GBS disease, which we just covered, also preterm labor before 37 weeks, and having a fever during labor.
Notice how those map directly back to the risk factors we talked about earlier.
Exactly. It's like the notes are connecting the dots. Here are the risks, and if you identify these specific risks during labor or from the history, this is what the guideline recommends.
Very logical. And finally, what antibiotic is preferred for IAP, according to these RCOG guidelines in the notes?
The notes are specific here. Benzyl penicillin. That's the antibiotic of choice for intrapartum prophylaxis, assuming, of course, the woman isn't allergic to penicillin.
Benzyl penicillin, another key detail.
Definitely one to remember from this guideline summary.
So this management section from the notes really paints a practical picture of the UK strategy described. Identify those specific risk factors listed. If present, offer intrapartum antibiotics, usually benzyl penicillin, treat confirmed infections. It clearly emphasizes prevention based on risk assessment, not universal screening.
Precisely. Mastering these specific points from the RCOG guidelines, as presented in these notes, is definitely crucial for revision, reflecting current UK practice.
Okay, so management is applied. What's the likely outcome? The prognosis. The notes touch on this.
The general message from the notes is actually quite positive. With prompt diagnosis and the right management, the prognosis for GBS infection is generally good.
That's encouraging.
It is. It highlights that the strategies, when applied quickly, are often effective.
But there's a significant but mentioned in the notes, isn't there?
Yes, there's a crucial caveat. They add that severe cases, particularly in newborns, can sadly lead to long-term complications or even mortality.
Right.
So it's a stark reminder of why spotting it early and treating it fast is so incredibly important, even though many cases do well with prompt kill.
Which brings us to the potential complications listed in the notes. What are those long-term issues, especially for newborns?
For newborns, the notes list things like ongoing sepsis, meningitis, especially if that was the initial problem, potential developmental disabilities, and other neurological sequelae lasting issues affecting the brain or nervous system.
Serious, life-altering possibilities.
They really are. It underscores the potential impact of severe GBS, particularly if it affects the central nervous system.
And for the mothers or other adults with infections.
The notes mention potential complications like postpartum issues, think wound infections after birth, or endometritis, which is infection of the womb lining, and also systemic infections generally, which could lead to problems depending on where the infection spreads.
So while newborns face those really severe neurological risks, GBS can still cause significant problems in adults too. Understanding these complications kind of circles back and reinforces why identifying risks, spotting symptoms, and managing effectively is so key.
Absolutely. So yeah, we've essentially walked through these revision notes section by section, trying to pull out not just the facts, but maybe a bit of the why behind them too. Linking the epidemiology to the risks, the transmission to what it does in the body, and the guidelines to the prevention strategy.
Yeah, we've distilled those pages down into, hopefully, a useful conversational deep dive, covering exactly what the notes presented from the basics of GBS right through to potential complications, with that strong focus on the UK management approach outlined. Hopefully this helps solidify the most important info for your revision.
Yeah, it's all about making that high-yield information from the notes really stick.
So maybe a final thought to leave you with based on our dive into these specific notes. Considering the notes state GBS is the leading cause of severe infection in UK newborns,
Right.
and that the UK policy described doesn't use universal screening, but relies heavily on identifying those specific risk factors and giving antibiotics during labor. What does this tell us about the absolute critical importance of clinicians being super vigilant about spotting those specific risk factors listed in the notes? It really puts the onus on clinical assessment, doesn't it?
It absolutely does. It highlights that certainly in the UK context presented here, knowing and applying those risk factors accurately is the main way to identify who needs that preventative intervention.
Mm.
Makes that list incredibly important, incredibly high yield for practice.
Definitely food for thought. But hopefully this deep dive into your GBS revision notes has been a valuable session, making those key points clearer and maybe a bit more memorable.
We've covered the essentials straight from the source material provided.
And remember, if you're looking for even more revision material like this, you can head over to passthemsra.com.
And don't forget to check out freemsra.com as well. Lots of great free resources there too.
Keep exploring, keep learning, and keep that knowledge sharp.